I'm going to share my screen. Okay, can everybody see that? Perfect. So, as Jillian said, she has asked me to do Y and HTC. At East Carolina University, I wear two hats. I'm the physical therapist for the treatment center, and I'm also the HTC clinical coordinator. So I work in conjunction with our financial person and the clinical team to help coordinate the care for our lifespan treatment center. Just a disclaimer to start with today. I am from East Carolina University, so go Pirates. So I am going to speak mostly from that HTC perspective. I'm not intimately familiar with all of the HTCs throughout North Carolina, but I am going to try to give a general overall perspective about comprehensive care at an HTC. But if you do have specific questions about your specific HTCs within North Carolina, please reach out to the different HTCs to ask those specific questions. And I think we have some representatives from them, or hopefully we have some representatives from them that can answer those questions. I'm also going to present some information about, our national network. So, but I hope I don't do too much of a slant toward ECU, but that is where I'm from. So our objectives today, I want to talk about what makes an HTC, what makes a center an HTC, who can and should be seen at an HTC, what are the benefits of a comprehensive care model at a hemophilia treatment center, how do you find a hemophilia treatment center, a little bit about your expectations of a hemophilia treatment center appointment, and some of the barriers about receiving care at a hemophilia treatment center. And I'm hoping that this is a really informal presentation. So if you have any thing to add or a question or a comment, please just speak up. And Jillian, if you could help kind of watch for those hands or comments, and I don't mind in the middle of the presentation. We don't have to wait till the end if anybody has any questions. All right, so the first one, what is the definition of an HTC or a hemophilia treatment center? According to the CDC, the definition of a hemophilia treatment center is it's a specialized healthcare center that brings together a team of doctors, nurses, and other healthcare professionals experienced in treating persons with bleeding and clotting disorders. Okay. HTCs provide patient care, education, and clinical research to improve the health and quality of life for people with hemophilia, von Willebrand disease, and other factor deficiencies. Some centers also provide care to persons with clotting disorders as well. And then the last definition part, bleeding and clotting disorders are rare, and outcomes are best if care is provided by a team of experts working in partnership with you and your family and other medical providers. So the one thing that's happening, I think, on a national and local level, even the Hemophilia of North Carolina is talking about logo and name, is Hemophilia Treatment Center just sometimes can be misleading because it just incorporates the word hemophilia. But one thing to remember in this definition is it does most hemophilia centers treat both bleeding and clotting disorders. They also treat von Willebrand disease and other rare factor deficiencies. So I think in the next couple of years, we will probably see a movement toward changing the name of hemophilia treatment centers to hemophilia and thrombosis centers, bleeding and clotting centers. So there's already some change in the names of these centers to be more inclusive of all the disorders that are seen at these centers. Okay, the next question to answer is who can be seen at a hemophilia treatment center or a bleeding and clotting center, or however the name of the center is. This is a lot of words. And on the next slide, there's a lot of words. And this is really to show that there are a lot of bleeding disorders. There are a lot of rare bleeding disorders. There are a lot of factor deficiencies. That is what is shown on this first slide. And ATHN is our national database. It's the American Thrombosis and Hemophilia Network. And if you are an HTC, you are most likely involved with ATHN, and that is, and most patients usually are involved in ATHN, and that is a database to be able to provide research and compare patients and just collect data across the nation and compare patients, because a lot of these diseases are rare. And all of these diagnoses are eligible to be included in this ATHN data set and ATHN database. So I included these up there to show that there are a variety of bleeding disorders and factor deficiencies. So I was just gonna let you look and see if you find yourself or if you know of anybody with these types of disorders. The most common, of course, are hemophilia A, B, and von Willebrand disease, but there are a variety of other rare inherited factor deficiencies. And then there are a lot of other inherited rare bleeding disorders and platelet disorders, as you'll see on the right-hand side of the screen. And then we also see genetic clotting disorders. So therein lies the potential for name changes, and that we don't just see hemophilia anymore at our HTCs, that we have broadened our scope of care. Okay. All right. Next. This is a lot easier to look at, the different types of HTCs. So the easiest thing is based on the types of patients that are seen, pediatric, adult, or lifespan. Most of the HTCs in North Carolina, and there are 5 of them, and we'll get to that in a few minutes, see both adults and pediatric patients. But across the country, there are either pediatric HTCs, adult HTCs, or HTCs that see both pediatric and adult patients, and those are called lifespan centers. And it depends if they see them in the same space, if they see them in different spaces, but those are basically your types of HTCs. So that's a pretty easy slide, self-explanatory. The biggest part of that type of HTC, and what is a main focus of many HTCs now and their goals and their objectives and a lot of their grant funding, is transition. Healthcare transition is the process of getting ready for healthcare as an adult. As a patient gets older, they must become more independent and responsible for their own health and medical needs. Previously, in the past, it was probably you saw your pediatric care provider till 18, or when you finished college at 22, and then you were just transferred over to the adult provider. Now it's become more of a focus, not only in hemophilia care, but also in many other care of chronic diseases, to do more of a transition process, to make it more education focused, let these young adults learn more about their disease and their healthcare management, and transition them, make it more of a process before they transition to an adult provider and an adult model of care. So most HTCs do have an organized transition process to assist their young adults achieve independence and confidence by preparing them for this adult model of care, to help them practice independent healthcare skills, and then to transfer to new providers or centers. In lifespan centers, it may just mean that they no longer see the pediatric providers and they just see the adult provider, and everybody else on the team is the same. In some centers, it just may be that you still go to the same system of care, but you just go to a different building. In some centers, you have to go to a whole new center. They may not see, pediatric or adult patients in their system of care. So it really depends, and that really affects the transition process. But it's very important that you go through this whole process to learn about how to manage your own care as an adult. Okay. The next question, why go to an HTC? Why can't we just go to a hematologist that, treats blood disorders? The biggest part of going to an HTC is the comprehensive care model. Each HTC provides access to multidisciplinary healthcare professionals. They have a multidisciplinary care team available to serve the whole needs of the patient. They have the hematologists, the physicians who specialize in the blood disorder, physical therapists, hemophilia nurse specialists, social workers, and other mental health professionals, and then other specialists either available by referral or, depending on the clinic, they may actually have them available in their clinic. This is what varies by clinic. Dentists, nutritionists, genetic counselors, orthopedists, and all of these specialists are very important in the care of persons with bleeding disorders. To be kind of designated as a hemophilia treatment center, you are supposed to have a hematologist, a physical therapist, a hemophilia nurse specialist, and a social worker available at all comprehensive visits. Those are the required specialists or healthcare professionals at each visit. It's great to have access to all of these other healthcare professionals to address all the needs of our patients. And then, all these healthcare professionals that work at a hemophilia treatment center have unique experience that qualifies them to work with persons with bleeding disorders. The hematologist is very versed in the medication knowledge and novel treatments and the newest tests to diagnose these bleeding disorders. And these are just a list of few. I didn't want to take up too much space on one slide. The physical therapist may be trained in the musculoskeletal ultrasound, which you'll hear about in a later talk today for physical therapy. Joint complications of bleeding disorders is a major thing with persons with bleeding disorders, and their physical therapist is trained in treating and evaluating those. Our nurse specialists are, accessing ports, teaching people on how to infuse factor, specialty treatment, factor referrals. The social worker, specialty resources for bleeding disorders, medic alerts. And the list goes on, but the team knows about what the bleeding disorder patient needs. That is why it is so important to receive your treatment at a hemophilia treatment center. To re-emphasize some of those points, comprehensive care provides services to meet all the needs of the patient and their family and loved ones. Every aspect of the person is addressed to include the physical, emotional, psychological, educational, vocational, and financial needs. And it includes support, education, and training over the lifespan to foster independence to ensure the best possible outcomes at all life stages. So the benefits of an HTC. The HTC staff understands the unique needs of bleeding disorders patients. The consumers receive help for not only their medical issues, but also their psychosocial concerns. There's collaboration among the over 140 HTCs nationwide for state-of-the-art medical care and most current research. So every HTC is part of a regional network, which is a part of the national network. And that network is connected for meetings and research and grants and working groups. So the PTs work together, the social workers work together. Ath and Dataset is all connected nationwide. So there is collaboration across the nation for persons with bleeding disorders. Also, development of comprehensive treatment care plans is a benefit of an HTC. According to a study done in 2000, a CDC study of 3,000 people with hemophilia showed that those who used an HTC were 40% less likely to die of a hemophilia-related complication compared to those who did not receive care at a treatment center. So that is a pretty significant number. Also, similarly, people who used a treatment center were 40% less likely to be hospitalized for bleeding complications. So if those bleeds were taken care of at a treatment center, then they were able to be addressed there without requiring hospitalization. Are there any questions to this point?
Not that I see in the chat, but does anyone have any? You can unmute yourself.
Okay.
Fleming, your question was, I'm learning more about your community. Would love to know how many appointments a month a newly diagnosed child with a bleeding disorder a parent may have to manage in the first year at the HTC and specialists.
So in the first year, if it depends on when they're diagnosed, but we tend to follow them more closely during their first year. So like we just diagnosed a new set of babies with hemophilia B, and we're following them every 3 months initially. Whereas typically with this mild hemophilia, we would only see them every 6 months. So it really would be on a case-by-case basis, but during the first year or first couple of years, as their development changes and, you know, they're learning a lot in education, we would tend to follow them more frequently. But it really would depend on, you know, the type of bleeding disorder and their complications and the comfort level with the family. But we do typically follow them more frequently when they're younger and new diagnosis.
Great. And then another question, you mentioned earlier about rare bleeding disorders. And again, we talked about, and I know we've talked about this with the treatment centers, again, hemophilia treatment centers, hemophilia North Carolina, we serve other bleeding disorders. Have you seen an increase now that more people are getting diagnosed? There's still a long way to go, especially women and people with BWD and stuff like that, but platelet disorders, Glanzmann's, are you seeing an uptick in people getting connected with the treatment centers, at least at ECU?
We have a huge population of von Willebrand's disease. So that's almost close to being more people seen with von Willebrand's disease than hemophilia. And we do have a large population. I would say for our numbers, we do have a fairly large population of rare bleeding disorders. I think it's also that we're able to diagnose them better because just, you know, our lab testing and things like that. So I think it's an awareness thing as well as testing. And I'm looking forward to hearing our talk on rare bleeding disorders to hear more about that. But yes, I think it's an awareness to know what's out there and that we can start tracking them and following them. And it's the same thing with women.
Great, thank you.
Okay, so where can I find an HTC? There are 5 hemophilia treatment centers in North Carolina. So there used to only be 3 for a long time, and we've welcomed 2 in Charlotte, and I can't tell you how long ago that was, but so we have 5 in North Carolina. These centers belong to the network of approximately 140 federally recognized hemophilia treatment centers in the U.S. And I did put up there, and because this is recorded and you can have access to this, the Centers for Disease Control, HTC National Directory, I put that website. You can click on that and you can put the zip code you're looking for or the state, and you can find a treatment center in that area that you're looking for. And I'll talk about why that's important in a minute. But there's about 140 across the nation. Are 5 in North Carolina, East Carolina University Hemophilia Treatment Center, and we are a lifespan clinic. We do adult and peds in the same facility. HTC, and if I say something wrong about what type of clinic you are, please let me know. HTC of Levine Cancer Institute and Levine's Children, they do adult and peds. St. Jude Affiliate Clinic at Novant Health Children's Hospital, they are just pediatrics. UNC Hemophilia and Thrombosis Center, they are adult and peds. I think they're at different sites, but they're one center. And then Wake Forest Baptist Health is adult and peds as well. So if you look at this map, this is the stars represent the 140 treatment centers across the nation. And if you'll see, I would hate to live maybe here in Montana because there is no treatment center there. And the reason is a treatment center is basically based on population. So 1 dot equals 1 patient. So there's only one patient here, a patient here. So their closest treatment center is way over here, or maybe it's in Washington. I'm sorry, my geography is terrible. I'm hoping I'm saying the right state. Or way over here in North Dakota. So you can see where there's more patient population, there are more treatment centers. And this map is a little old because you see North Carolina only has its 3 treatment centers, unless that was Charlotte, I could not tell. But as the population density of patients with bleeding disorders increases, then they can apply to the CDC or, to become a treatment center. So where there is more dense population of patients, there are treatment centers. But some states don't even have a treatment center at all. So some of the barriers I'm going to talk about, you can see where in some of these states, they would have a lot more barriers to receiving their care at a treatment center than say we would here in North Carolina, because we are very fortunate that we do have 5 treatment centers in one state.
Laura?
Yes.
This is Rick. Good morning.
Good morning.
Just wanted to throw a comment at you. It's interesting when you mentioned Montana. We have lived in Canada 2 different times. And one was in Alberta, which is straight above Montana. And fortunately, there was a hemophilia treatment center in Calgary in Alberta. And it was the same high quality of all the others that we've participated with over the years.
Well, that is great, because I'm sure that was closer than some of those other places they had to try to get to.
Yeah, it's a long way to everything in Montana.
Yeah, probably especially in the winter.
And Laura, we had a question. Can we get a copy of this map? Or do you know, is it available online?
It is. I got this. It is. And I'm sorry I didn't put the reference, but it is. It was available. It's on the CDC website.
Okay. I'll email you afterwards. And if you could send me the link.
I can.
Or if I can find it myself, I'll try. And then Kathy, I'll make sure it's available. Maybe it's something, Jillian, when you send your recap email, if you can
Yeah.
share that.
And it's from the university data collection study. So it's, like I said, it's the most updated one I could find. So there may be a couple of more. I don't know that it includes all 140 of ours, but because I'm not sure that this is Charlotte. So, but it shows the point of that some states don't have any at all, whereas the more populous areas have more treatment centers.
And then another question that came in shortly after we switched gears from the question about the rare bleeding disorders.
Mm-hmm.
Do you know what the ratio would be for Glanzmann's and Bernard Solier? And I'm sorry if I'm butchering. Solier.
Mm-hmm. I don't have any idea what the ratio of that. I know we actually have one of those each at our center, but I have no idea what the ratio is of that.
And I know there's a few in North Carolina
Mm-hmm.
on the different treatment centers information. So, but good question for the breakout session for the rare bleeding disorders.
Yes, that would be great. But we do have, I mean, I know we have one of each of those patients at our center. And then, so I don't know about the ratio at other centers, and they are very rare. So that is, that is very untypical, but interesting question. I don't know that answer. Okay, so why, I'm gonna leave this map up, and I'm gonna talk about why is it important to know, first of all, maybe this website, and you can find this website at the CDC as well, and also to realize that there are HTCs around the country and that we are a connected group. We collaborate with 140 HTCs. And why is that important? First of all, it's important when you're traveling. So like if you're traveling across the country, or if you're on vacation, these different HTCs have access to your information if the patient is a part of their Athens data set. If you are a part of clinical manager in Athens, your information is in that database. So they can see the patient, they can see if the patient gives them permission, they can see what type of treatment, but we are a connected treatment center network. So traveling, it's always important to have your medic alert and your emergency information and your emergency treatment plan, that if you're going to be gone for an extended period of time, traveling and knowing where the closest treatment center is always a benefit to be able, if you feel like you need to have your treatment there. The other thing that I think we run into more often is our children going to college. So if they're going to be going to college, you live in Greenville and they're going to college in Charlotte, you can share these patients between HTCs, so they can receive their care at one of the Charlotte HTCs. They can still remain our patient as our primary patient, but they can receive their care for the next 4 years if they need anything emergent wise or whatever at the Charlotte HTC. So it's important to know where these HTCs are for that reason, and to be able to connect with them or talk with your primary HTC about making those connections with a shared HTC.
And Laura, we had one other question related to the map. Do you think that the population is low due to the inability to test in rural areas?
Well, I'm sure that probably has a lot to do with it. Yes. And, you think about out west, I know I'm on a national working group. I'm the chair of the PT working group. And so I have people that I meet with that are out here, and even this center, to even get to their patients across, there's mountain ranges. A lot of this is very rural. So they have a lot of challenges in these very rural states. So yeah, I'm sure testing, you know, getting people to come to appointment, you know, even though if they have a bleeding disorder.
And I'm guessing too that some of the data might not account for people who are going to one-off hematologists because they're not going to travel that far to an HTC. And then the other thing I was going to mention too is we do have people call us. I know of folks who moved to North Carolina because of the care that there is here for bleeding disorders. So I think some people really take, I mean, a lot of people probably take it into account, but some weigh it pretty heavily. And then we've had phone calls from people that are looking to move here, and they'll tell us what city and is there a treatment center near me? Like that is just so important to them that they want to check this out before they move. So
Yes.
I could see that being another factor.
Yes. So we talked about this traveling, going to college. HTCs can share patients and then still serve as their primary HTC. Okay, so what about what to expect at your HTC appointment? So one thing that we sometimes hear a lot of times is the HTC appointment is so long. We have to wait forever. We've tried to make ours more efficient. We're always working on our workflow. I know all the other centers are working on their workflow as well. So there's different types of visits. I think that's one thing to keep in mind. Your comprehensive annual visit, there's certain requirements that we have to get at that visit for our research, for our CDC grants. So you have to get certain labs. You have to be seen by a certain number of our healthcare professionals. So that does tend to make that visit a little bit longer. Then, you know, there's a follow-up visit, or some centers call that a prophylaxis visit, that if you're on long-term prophylaxis, they, you know, or you're based on your diagnosis, if you're a severe patient, they like to see you every 6 months. Then you also have an acute bleed visit where you may only need to see the PT and provider, or you may just be coming in for just a PT visit. If you're on a research study, you may just be coming in for just a research visit. So there's different types of visits. And I think when you think about what type of visit you're having at the HTC, then that helps you to determine how long to expect to be there. And I think just kind of going in knowing that your comprehensive or your annual visit is going to be a little bit longer, because you do have to see more people. We have to do 2 surveys and have to see everybody on the team, and just know that we're working the best we can to try to improve the efficiency and the workflow of those clinic visits. Like I said, all needed healthcare professionals have to see those patients. We have research and data collection requirements, surveys and regional requirements that we have to meet at those comprehensive annual visits. A lot of times the patients now, I don't know if all the Charlotte and Wake Forest does musculoskeletal ultrasound, but I know I do that, and I think UNC does that pretty regularly. Patients love to have that done. It gives them a good look into their joints. We'll talk about that at the PT session. Then they have to have labs. Some centers are able to do imaging. So by the time you add all of those things into a visit, it can make the visit quite extensive. And then if they have genetics and orthopedics and all those other things. So just those are some things to keep in mind and to expect at a visit.
And I know, thank you, Dr. Bryant, at St. Jude, we do as well.
Perfect. Thank you for answering that question. So I think we've kind of discussed some of these barriers to an HTC visit as far as distance to the HTC. I don't think that's such, it may not be seem like such a barrier now that we've looked at the overall map, but say for East Carolina University, we cover a 29 county catchment area. So east of I-95, we're the only HTC. So people in on the East Coast, way on the, Outer Banks, for them to come to Greenville for an HTC appointment, that can be very difficult for them. Work schedule, school schedule, paying for gas, so the distance to the HTC can be a barrier to receiving comprehensive care at an HTC. Also, insurance coverage sometimes is a barrier. Some patients just don't have insurance coverage. If they do have insurance coverage, it's considered a specialty appointment and it has a higher copay than just seeing a primary care doctor. So that can also be a barrier as well. I was going to ask, we do have a few minutes. Does anybody else, I wanted to kind of open this up to the audience, any other barriers that that you have to receiving comprehensive care at an HTC? Well, that's good to know if there's none.
I'm gonna say, yeah, that's nice. I do hear, like you said earlier, some people will say about the amount of time it takes and just needing to take a full day from work can be a barrier. But again, if there's no complications, it being every 6 months or every year, or in some cases 2 years, depending on the person and their situation. I've never heard somebody say that they don't go because of that. They just might have to schedule accordingly.
Right.
And I hear a lot about the distance too, like being a challenge, especially when they're going more frequently than once a year. But even for the once a year, if you're driving an hour and a half or 3 hours, or if you're in the Outer Banks, it's going to take you a really long time to get to Greenville.
It does. And we do, thanks to y'all, we do offer gas cards to try to offset some of those costs of coming that distance to, at least to our center, for those patients. Well, good. I'm glad to not have a whole lot of discussion on that. So that is what I had for what and why and who for an HTC. I will be glad to take any questions or any thoughts or experiences I have 3 minutes left. I think or 4 minutes left maybe, or any of your own barriers or any questions at this time to wrap up this discussion today.
Lori, I have a question.
Yes, ma'am.
This is Kathy Register.
Hi.
Do you know of a similar group, similar to Hemophilia of North Carolina, that serves people with clotting disorders?
There is, and I can't tell you right off the top of my head, but I have it. Mm-hmm. But I can get get that information.
I guess, and I don't really need to know specifically the answer. My question is there a need for that? And do you see as active a group, and are there as many constituents and so forth?
I don't know that there's actually a advocacy group like Hemophilia of North Carolina, but there is like a clotting disorder website and information and link, and Charlene is shaking her head, so she may actually have that information right off the top of her head, but there is, and I think we definitely need to have that information more available to people, because we need to address both ends of the spectrum of these bleeding disorders, bleeding and clotting.
Well, this was an excellent presentation. Thank you very, very much for it.
Well,
there may be more questions. I just wanted to throw that in.
Well, thanks. I appreciate it.
And I'll say, as we're looking to change our name to bleeding disorders, we recognize that we have got to really define who we serve with bleeding disorders, because some would look at that as being sickle cell or clotting disorders and stuff like that. So Jillian and I have been collecting different rare bleeding disorder types from various colleagues, and even Athen gave us a list of types of bleeding disorders and stuff. But one of the other things we're doing is creating a resource list for folks that have blood conditions like clotting disorders and stuff like that, that we will not be within our definition of who we serve, so that we can at least direct them to an organization or resource for their condition. So I do have some, and there are some, but they're not as active. We do have an active sickle cell group in North Carolina, which is nice, but other clotting disorders, not so much.
Yeah, Charlene, I think with Lori explaining to us that the HTCs have really expanded into not just bleeding, but clotting. We might need to have a nice agenda item on our board about this.
Yeah. Yeah, most HTCs are addressing both the whole range of bleeding to clotting. So
Thank you.
So I received a question in the chat, and I'm sorry I've had to step away on and off to get Noah ready for soccer this morning. So I don't know if you addressed this already. But the question was, what determines what disciplines an HTC has beyond the, required doctor, nurse, social worker, and physical therapist?
Really, funding and availability, and those are, the team deciding, and if they can get those people to be able to be available for clinic, those types of things.
Does anyone remember when they got connected with their HTC? What was that first appointment like? Did you have a history of bleeding disorders, or was it you or your family member got diagnosed and were told this is where you need to go? I'm just curious.
My mom, she was when she was diagnosed, she was in the hospital. So you guys are kind of familiar. She received 48 units of blood when she first was diagnosed with the bleeding disorder, and we were at Johns Hopkins Hospital. So we went directly after they stopped the bleeding, and she was on a regimen. She was downstairs at the HTC there, and that's when they gave her infusions. And then when we transferred, now we came from, my mother was in Maryland, so I brought her here so that she could be close to Dr. Ma and Dr. Oh my goodness. Well, Dr. Ma at the time, I can't think of his name. I'm kind of slow this morning, but we went to the HTC right there in Chapel Hill. And that's where she received her infusions. And I'm so glad that the social worker, the nurse, all the doctors were there, and they were able to, if I answered that question right. So we did come from another state to make sure that was a connection. And that connection came from Johns Hopkins Hospital, who researched that to make sure that she was able to get what she needed to get, since she had to be here with her family now, So that was good.
That's great. I know, and your mom is an extremely rare case with acquiring hemophilia.
Yes, and acquiring.
We only have a few folks in our database that have acquired hemophilia.
Okay, yeah, because at 87, she's going to be 90 in November.
Wow.
She acquired it at 87 years old, and what they did mention was that it usually doesn't happen to women. What happened to her? They see more men at her age with acquired hemophilia. She had factor VIII, so it's just something. It is rare, and it is strange, you know, and it's different. They said 1 in a million. It happens to 1 in a million people at that time. That was in 2007, 18, 19, 20. Yes, 2018.
Wow.
Wow. Yeah.
Yeah, I know it all blurs together these days, right?
Oh boy, I have it written down because I think it's an awesome conversation to have, especially when we advocate that it could happen to anybody and any dynamics, whatever their lifestyle is or life choice or wherever they live or whatever their financial situation. We are so blessed that we were able to get the assistance and help, and my mother had never been to a doctor ever. And for her insurance, oh boy, everything hit her insurance policy. Wow.
Oh.
That was a lot.
I'm glad she was insured.
Yes, a retired nurse. I mean, you wait until, you know, things like that happen after, you know, long time later. So thank you guys. Wow.
Thank you. And Laura, do you know, I know you showed us the map, but, and this is almost a question I know the answer to, but is it unique to have 5 federally funded hemophilia treatment centers in one state?
I think so, probably for this, because there's states that are larger than ours that don't have that many. So I think it is.
Yeah. And then one thing that I'll say, and again, just having the experience of working with other advocacy organizations like ours around the country, not only are we fortunate to have 5 in our state, but that work well and coordinate and collaborate with one another. We have a North Carolina Advisory Board for bleeding disorders where all of our treatment centers are represented and share with one another. And then events like this, you know, getting together and making sure that patients are educated and collaborating with Hemophilia of North Carolina. We are very fortunate to have that because a lot of states do not have relationships like we do in North Carolina.
Right. That's true.
So, well, thank you very much. Is there any other questions? Okay, I'm gonna stop recording.